This is the Interventional Radiology Grand Round. It's wonderful to have a lot of people here early in the morning. It's our pleasure and the distinctive honor to have Dr. Peter Glazer here as our speaker. The younger folks in the crowd may not necessarily know, but the radiation oncology used to be part of us radiology as a whole. In fact, still the radiation oncology, radiology, we are under the same roofs of ACR, ABR, and RSNA, amongst others. The Dr. Bill Casarella, who was the chief of IR at Columbia, then chair of radiology at Emory, used to tell me that one of the best things he has done as a chair of radiology was to motivate and help to establish the Department of Radiation Oncology at Emory, which subsequently then flourished ever since. This is the fantastic to have Dr. Glazer here to share the radiation oncology here at Yale with us. He's the Robert Hunter Professor of Therapeutic Radiology and Genetics, received the MD and the PhD here at Yale, and trained here, and has established not only for his research, but also radiation oncology research and the clinical enterprise here at Yale so prolifically. And he's obviously a world-renowned researcher in radiation oncology. So without further ado, Dr. Glazer.
So thank you very much for that introduction, and let me get the clicker out here. So thank you for having me. I just want to start out with this. Was taken from a BBC website. It's a few years old, but I've given a talk a little bit similar to this to the dean and the department chairs in the med school, because every few years each department presents, and I always would make sure that the director of the cancer center was present. We're about to get a new cancer center director, as many of you know. Tom Lynch has left us, but Charlie Fuchs is coming, and I'm hoping to show him this slide because as much as there's excitement about some of the new approaches in medical oncology, as many of you will appreciate, radiotherapy does cure cancers, and as the BBC says, although cancer specialists actually in UK, people are oncologists there, and they do both radiation and chemotherapy, prescribe both, the public has been led to believe that new chemotherapy drugs offer the greatest promise. But the reality is that surgery and radiotherapy are the main curative treatment for cancer in adults. So I think this last sentence may turn out to be not exactly true with the new immune checkpoint therapies that are having some great success, but we're still going strong, and I'm going to tell you a little bit about what our department does. So a little bit about the history. As Dr. Kim mentioned, typically radiation oncology and diagnostic radiology departments historically have been fused, and that Yale was no different. And interestingly, our history sort of begins in the 50s, and Mort Kligerman was the chair of the Department of Radiology, but he was actually a radiation oncologist. Now, at those times, residents trained in radiology, period, and you just decided what your specialty was because you rotated both in therapy and in diagnostic, and then you sat for whichever boards you wanted to go into. So he was a radiation oncologist, but he was chair of basically a unified radiology department for 14 years. But then when he left Yale, the decision was made to split into two departments, and that's where the name Therapeutic Radiology and Diagnostic Radiology emerged. And Jim Fisher became chairman at that time, and actually was chairman for 30 years. And then I took over for him about 2002. And so actually there have only been two chairs of therapeutic radiology at Yale in the history of the department. as a separate department. Now, in the 50s, we got a big donation from the Hunter family that constructed the Hunter building. That's a funny building over there because it's a university building but on hospital land. So it's kind of a shared building that each floor has a different allocation. We had the first mega voltage radiation treatment unit in the region installed in the 50s, and that also was purchased with a donation to the university and then given to the hospital. That's an unusual transaction that I don't know if it would happen that way these days. And then 1959, under Kligerman, the radiobiology section, so the basic laboratory section of what was radiology at that time, but then veered off into therapeutic radiology, was founded by Paul Howard Flanders, and that was a very important recruitment, as I'll mention in a few minutes. And then after about 50 years, the Hunter Labs finally got renovated, and we had an NIH construction grant, and if you walk on the second and third floors in Hunter now, you'll see that the labs are really quite nice. And of course, everyone knows that Smilow Cancer Hospital opened a number of years ago. And then we moved our clinical operation. It was in the basement of Hunter, and in fact, the bunkers are still there, but the clinical operation in New Haven was moved to the basement of Smilow. But we have other clinical sites that I'll tell you about. So getting back to Paul Howard Flanders, he made a seminal contribution in the area of radiobiology and really tumor biology and carcinogenesis in the early 60s, because his lab, along with the lab of Richard Setlow, also at Yale in the biophysics department, and Phil Hanawalt was a grad student under Setlow, they co-discovered the process of DNA repair. So way back when, in the 50s, after the whole atomic era evolved after World War II, there was a discussion about whether damage to DNA from radiation could actually be repaired. And this was something that was very important to everybody, both for military reasons and medical reasons. And actually, there was requests from Washington for scientists to look into this, and it was work done by Howard Flanders and Setlow that first showed that damage to DNA could be fixed. And this established a long tradition in our department of studying DNA repair. A number of key discoveries mechanistically were made in our department. The molecular mechanism of nucleotide excision repair, which is the repair of UV damage from sunlight. The REC-A pathway, which does DNA recombination. And actually, one of the groups that linked DNA mismatch repair to colon cancer was in our department. That was Mike Liskay's lab. So we're very proud of this. So just about a year ago, the 2015 Nobel Prize in Chemistry was awarded for DNA repair. And the winner, one of the three winners, was Aziz Sankar. And the work cited by the Nobel Committee on their website, the seminal work, was this 1983 paper in Cell with Sankar and Roop. And Dean Roop was our longtime faculty member. He just retired a couple of months ago. And they worked out the mechanism by which the nucleotide excision repair pathway functions. That is, removal of thymine dimers and bulky adducts. Aziz went on to University of North Carolina, has had an illustrious career, and he was awarded the prize, although the work was done in conjunction with Dean. And I just want to say that he was actually a fellow on our T32 training grant. At that time, we had one of the first T32 training grants from the NCI. And so he was actually a trainee in our program in the Cancer Center. So let me tell you a little bit about the faculty. These numbers are evolving. This slide I needed to update, but roughly we have about 9 radiobiology faculty at different ranks. We're proud to say 6 of them have joint appointments in basic science departments, including genetics, MB&B, pathology, or pharmacology. And also we're pleased that one faculty member in MB&B, two in MB&B and one from genetics have chosen to seek joint appointments in our department. We have, actually, now we have 15 medical physics faculty, and we have around 24 or 5 clinical faculty, and the clinical faculty include one joint appointee from neurosurgery, that's Veronica Chang, because she works with us hand in glove at the Gamma Knife facility. So in the radiobiology and physics section, we have something like 12 graduate students, 18 postdocs. We have 6 MD PhD students doing their theses in our department. We have a T32 training grant, which we just got in conjunction with pathology. It's a training grant in cancer biology. We used to have one in radiation biology, but now it's broadened to cancer biology. We have a number of people that have played national leadership roles. Lynn Wilson, our vice chair, is one of the board of directors of ASTRO and is often a leader at our annual meeting. And our society, as many of you know, is called ASTRO, and that just gets a little bit to the naming. So as I mentioned, we split off from radiology and became therapeutic radiology. Recently, when Dr. Geschwin arrived, he talked to me about maybe changing the name to radiation oncology, because I know your department has changed the name, but we're kind of old school and we stuck with it. But the society used to be American Society of Therapeutic Radiology and Oncology. They changed their name to American Society of Radiation Oncology, but thankfully kept the T in the acronym. So we're still ASTRO and not otherwise. And our faculty play a role in the wider university as directors of the Radiation Safety Committee in the university, and actually on the hospital side as well. The Biological Safety Committee, actually Dean Roop was doing that and he just stepped down, so they're going to have to replace him. And we run 2 core facilities, the cesium irradiator facility and the biophysics facility that Joanne Sweezy runs and is housed in LCI. So our research interests run a gamut. They focus to a large extent on aspects of tumor biology, tumor hypoxia, stem cells, genetic instability. A big focus on DNA repair with studies on DNA polymerases, a genomic study of DNA repair gene mutations and germline variants in people and what that means for cancer risk and response to therapy. A big interest in regulation of DNA repair and how that can be exploited for cancer therapy. We have one of the national experts on the BRCA2 protein in our department, Ryan Jensen. And we have a fairly robust drug discovery program with several investigators looking for new modalities, both as standalone agents and to be used in conjunction with radiation therapy. We had a long-standing program, project grant in DNA repair, that ended a couple years ago, but we're looking to reconstitute it as a SPORE, a thematic SPORE. Some of you know that NCI has disease site-oriented SPORE grants, but now they're allowing thematic SPORE grants, and we're looking to submit one of those. We also have an interest in developing novel cancer biomarkers and using circulating tumor DNA for looking at tumor burden and developing novel therapies. And I'll give you some vignettes on these also. In the physics area, we have some things that I chose some of the work we're doing that overlaps a little bit with diagnostic radiology interests. We have 2 collaborative programs working with the PET Center. One is David Carlson working with Rich Carson to detect hypoxia in tumors by PET methods. And the other, Joe Contessa with Evan Morris, and I'll tell you more about that one. And some other things, Jun Dang is looking at ways to personalize imaging, both for diagnostic and therapeutic treatment planning to minimize dose. And we've had a long-standing interest in developing novel dosimetry approaches, especially in using radioisotopes in brachytherapy. So just to, as a benchmark, and these types of comparisons vary year to year, but somebody actually spent the time to calculate what's called an H index. Some of you may know that that's sort of a measure of research productivity, but not for an individual, but rather for radiation oncology departments as a whole. So when they did this a few years ago, our group came out tied for fourth, and you can see we're pretty much close to, MD Anderson and Stanford. There's not much difference. There's Harvard's way at the top, but really that's a combined program among several departments up there. So the size makes that comparison a little unfair. So we're doing pretty good. The only thing I would point out is that the vaunted Sloan Kettering is way down here. In fact, I'm kind of surprised they made the list. So anyway, in terms of research funding, and this is a few years old, but as some of you know, I think that if you look on the NCI website, they don't separate diagnostic and therapeutic radiology. I remember talking to Jim Duncan. I think your group does quite well, but we're doing pretty well too. But we had to, one of our faculty actually manually went in and used the NIH reporter to try to calculate these. So these are unofficial rankings. But as you can see, we're in the top 5. We're actually doing a little better this year. We have between 5 and 6 million in direct costs, but I don't know where the other players stand on those rankings. But this is probably a pretty reasonable estimate. So let me tell you a little bit about some of the research we're doing, and then I'll get basic research, then I'll get into the clinical side. So this is work by Joe Contessa that's really turning out to be very exciting, and he developed a high-throughput screen for molecules that would inhibit the glycosylation of proteins. So this is a diagram here showing sugars being put on a protein and all the different steps in the maturation of a glycosylated protein. Now, why is that important? Well, it turns out a lot of growth factor receptors have to be glycosylated to function, and as many of you know, growth factor receptors like EGFR, HER2/neu, and others are the targets of antibody therapy like cetuximab or Herceptin, as well as small molecule inhibitors, of the active site. But Joe had a different idea, which was to inhibit their biogenesis, and he actually found a compound, and he's shown over here that, in fact, there's a well-known sort of poisonous compound called tunicamycin that inhibits this pathway, but it's just generally poisonous, and it couldn't be used therapeutically. But what you can see here in an EGFR-addicted tumor, this is the control. Here's tunicamycin, but here's his new compound. Okay. In contrast, if you look at normal fibroblasts, his compound has no effect. And interestingly, it has no effect on a lung cancer that is not EGFR addicted. So it has high specificity. So this is a very promising compound. The only thing main challenge he's still working on is it doesn't have enough solubility to get high enough doses in people or animals yet. But once that medicinal chemistry problem is solved, this could be a very interesting compound to take to the clinic. So another screen was done by Ranjit Bindra, and what he did was this is a radar plot of hits in a screen, and what he's measuring is here, and I can't give a whole talk on his work, but he developed a very clever cell-based screen to measure DNA repair by recombination. And so recombination, as many of you know, is one of the 2 main ways that DNA double-strand breaks are repaired. And of course, radiation generates double-strand breaks. Everyone in this room knows. So he screened thousands and thousands of compounds, but thankfully he included in that screen some panels of existing FDA-approved compounds. And he found a compound called mibefredil, which actually is an FDA-approved medication with the brand name Posacor for hypertension. It's a calcium channel inhibitor. And he found it's a potent DNA repair inhibitor, radiosensitizer. and he initiated a phase 1 trial for recurrent glioblastoma, and the trial snapshot is shown here, where there's as much resection as possible for the recurrent disease, but then there is treatment with mivefredil, and then what we call hypofractionated stereotactic radiosurgery, which is relatively high dose of 600 centigrade given 5 times with the drug. He completed accrual to his trial, but he actually got some very promising responses. And so this trial is now going national. One of the cooperative groups has picked it up. So this is also very exciting because it's an existing medication. So it's been a very rapid bench-to-bedside program. Another new molecule that is being developed for cancer therapy was identified by James Hansen, another young faculty, and he found a very interesting lupus-derived autoantibody. And as many of you know, lupus is an autoimmune disease that makes anti-nuclear antibodies, many of which bind DNA. But the interesting thing about this antibody is it penetrates cells, and he found it also inhibits DNA repair and sensitizes tumors to radiation. So this is a Kaplan-Meier curve of tumor growth in a mouse, and this curve out here is the antibody plus radiation showing an improved response. We also see increased cell killing and synergism with doxorubicin, and that is particularly strong in BRCA deficient backgrounds. So this is also a very exciting molecule that James has licensed to a biotech company and is being developed to take into a phase 1 trial. And interestingly, he's got a panel of these antibodies because there's a number that have interesting properties. And what's very intriguing is some of you may know that women with lupus have a lower incidence than you would expect of breast and ovarian cancer based on the general population. So there's some speculation that some of these autoantibodies may be slightly protective against malignancy. So speaking of lupus, Joanne Sweezy made really a seminal discovery very recently when she was looking at some DNA polymerase variants and what they do in mice. So she started out thinking some of these variants might cause more mistakes during replication and therefore would lead to mutation and cancer. But she made the very interesting observation that when she expressed the mutant version of polymerase beta in mice, this particular mutation, the Y265C, the mice developed symptoms of lupus. Okay, and this is the number of mice as they grow older showing lupus symptoms, one of which is development of anti-nuclear antibody titer in their serum. And interestingly, a single nucleotide polymorphism linked to susceptibility, propensity to lupus, is in linkage with the locus of the Pol beta gene in people. So it raises the possibility that one of the etiologies of autoimmune disease may be subtle variants in DNA repair factors that lead to excessive somatic hypermutation in antibodies and autoimmune response. So this is crossover between DNA repair and immunology. It's very interesting work. Doug Brash had a paper in Science last year where some of you may have seen this in the news media because it was picked up on, in the New York Times and the Today Show and places like that, because it turns out that UV light doesn't just cause damage while you're out in the sun, but he found in a complex pathway that I'm just showing you a picture because I can't explain it. The UV light creates an excited state in melanin that takes hours to resolve, and even when you're in the dark, the chemical cascade that happens from that generates DNA damage. So it's opened up a whole new area for sort of the sunscreen industry to try to figure out ways to mitigate that. So stay tuned on that. But that also is a whole new paradigm in really how sunlight causes DNA damage. And then a work that I was involved in and has some implications for diagnostic approaches too is that I worked with Don Engelman, who developed this unusual polypeptide called FLIP for pH low insertion peptide, because in low pH that you find in a tumor environment due to the buildup of lactate from the high glycolysis, really, as you know, that's the basis of a PET scan, you get the polypeptide takes on a helical structure and then inserts in a directional way across the membrane. Now, we had a paper in Nature last year where we used an antisense peptide nucleic acid to inhibit a specific microRNA. But the point is, this is a delivery vehicle that can target a tumor, and you can see here when this is labeled with a fluorescent dye, and you inject a mouse IV, basically this hones just to the tumor. It's highly specific delivery. Now, what does that mean? Well, getting together with Wu Lu, one of our physicists, and John Deacon in the Engelman lab, we're now pursuing the attachment to this very powerful polypeptide as a delivery tool to gadolinium nanoparticles. And we believe that that potentially could be used to enhance imaging of tumors, even very small ones, because it will decorate even small metastases with these nanoparticles. And secondly, we can either decorate them or we can flip it around so they get inserted. And we're looking at the possibility that gadolinium as a high Z compound potentially can absorb radiation and generate secondary emissions that could potentiate the radiation. So it's a potential as what people call a theranostic compound, both diagnostic and therapeutic. So this is an exciting project that we're just starting now, so I don't have anything more to say about that. So let me switch gears and talk a little bit about the clinical activity and some of the clinical research. So we're scattered around the state, and these are some of the locations and when we started. Actually, we used to be up here in Bacchus Hospital from 1962, but as some of you know, Hartford Hospital bought Bacchus Hospital, and they eventually kicked us out, and that's sort of the politics of healthcare in 2016. But we have a larger department than we would if we were just sitting in New Haven, because we provide clinical service to multiple sites, as you can see here. So we have about 24 physicians. Actually, I'm not sure if this is quite accurate. I see Ravi's in the back, but we have some number like that. And we provide services to these facilities, and we give between 90,000 and 100,000 treatments per year, and we use 12 linear accelerators plus a gamma knife for stereotactic radiation to intracranial lesions. And we have a number of specialized programs. I mentioned the gamma knife. We're now using this very interesting modality called Calypso, which basically generates a GPS signal, and we insert, or the urologists insert these into prostates that need radiation, so we can follow the movement of the prostate during treatment. I mean, you might think prostates don't move that much, but they really do. And for us, when we want to give highly focused radiation treatments and spare the bladder and the rectum, it's very important to track the motion of the prostate in real time. And this is a very nice tool. As I said, we also have a very robust program in brachytherapy, the insertion of radioactive seeds into tumors. And we're one of the few places in the country that do total skin electron beam therapy for cutaneous lymphoma. And that's been a long-standing program in our department. So one of the new directions in radiation oncology over the past 5 to 10 years has been what we call hypofractionation, which means using fewer fractions but larger doses. Conventionally, radiation treatments evolved to give multiple treatments over 5 to 7 weeks of 2 gray a day for 30 treatments to tumors. And the idea being that that helps spare the normal tissue and has other radiobiological advantages. But with the improvement of the precision of radiation treatment devices, the computerization, allowing reverse dose calculations, the field has been able to go to higher doses and fewer fractions. And so one aspect of that is called stereotactic radiosurgery, and Roy Decker in our department has been a leader in this area. And it used to be that in stage 1 lung cancer, radiation was not considered a helpful approach, but in the past few years that's been turned on its head, and in fact, a very focused radiosurgery for early stage lung cancer is rivaling surgery in its efficacy and probably with fewer side effects. Because you can see here, what we do is we do multiple beams that are calculated to give very precise dose distribution around the tumor. And with this, we track motion, because obviously there's motion during breathing, and we have methods to do that. And this allows us to give very high doses. So typically, we might give 18 to 20 gray in a single treatment and do it 3 times. So that's well over what's called a biologically equivalent dose of 100 gray. But it's turning out that that can be given safely and effectively, and we're getting some very nice long-term, essentially cures of stage 1 lung cancer, starting out with medically inoperable patients, but now we're starting to get all comers. I mentioned we're interested in biomarkers, and Abhi Patel has been a pioneer in detecting, using very fancy PCR and deep sequencing techniques, detecting circulating tumor DNA in blood. And this is now being applied for early detection of malignancies with a big thrust on ovarian cancer, but also as a way to follow tumor burden. And here's an example where you can detect a low level of circulating tumor DNA in a patient with that small lung tumor. You hit it with that stereotactic radiation therapy, you get a burst of circulating DNA from the dead cells. But then if it's effective treatment, it comes down to undetectable and it stays that way. And it turns out in serial studies that Abhi and others have done, the detection of the circulating DNA in blood can precede the ability to see it on imaging studies. I mentioned our strong collaborations with the PET Center, and this is work that Joe Contessa and Evan Morris published, and Joe had the idea to use labeled erlotinib, which many of you know is specific for mutant EGFR. It's an inhibitor of the active site of the mutated EGFR protein. And they showed that this specifically will light up tumors that have the mutated EGFR, but not tumors with wild-type EGFR. So it's a very nice application toward molecular-based imaging that they're pursuing, and they recently got a joint R01 to pursue that. Another collaboration with the PET Center that Roy Decker and David Carlson are doing is using F18 labeled mesonidazole to detect hypoxia in tumors. And one of the ideas is that the radiosurgery, a high dose of radiosurgery could collapse the vasculature in the tumors and lead to sort of a broad hypoxia in that tumor. And studies actually in our lab and others showed that in hypoxia DNA repair is suppressed, and that creates a potential sensitivity to a PARP inhibitor, in this case olaparib, which many of you know was recently approved by the FDA in the setting of BRCA-deficient tumors. So this is an interesting study that received pilot funding from the Cancer Center, but will be included in that SPORE that I mentioned. June Dang, one of our medical physicists, has been interested in personalized protocols for imaging, and this applies both to diagnostic CAT scans as well as the CAT scans we do for treatment planning. And actually, we do often we do a CAT scan, a cone beam scan, on every patient, immediately before we treat them to make sure their localization of the tumor is correct. So our patients get a lot of dose, not just from the therapeutic dose of the LINAC, but actually from the cone beam CT dose. And we're very interested, as is the field, in minimizing the extra dose, because as you know, that gets spread out, that's not focused. And we want to work to minimize that. So he's been a leader in that area. Another very interesting clinical study that has a lot of promise is work that Sue Higgins is leading, and this is in conjunction with Tommy Chang in pharmacology. He found that this Chinese herbal remedy, which has the company name PHY906, he's founded a company called Phytoceutica, will protect intestinal epithelia from radiation. So it's a Chinese herbal remedy for nausea and vomiting. And it's being used in conjunction with chemotherapy to reduce nausea and vomiting. But if you look at the effect on the intestinal epithelia, you can see that in mice, giving them this prior to radiation protects the integrity of the intestinal epithelia from radiation. So we're very excited about this. It's in a phase 1 trial that Sue is running here and in our network. And we're hoping to see positive results. It's being done in conjunction with pelvic radiation for various indications. So our residency program, our director is Roy Decker. We have 14 residents, and our residents work here. They also go to Lawrence Memorial Hospital in New London, and they cover the VA. All of our residents get a full year of research time or elective time in their 4 years, and we like diagnostic radiology. We have the Holman pathway available. It is a competitive residency. We don't have to go down far to match, and we get a number of MD PhD applicants, and fair number go on to academic jobs, but we're proud of our trainees no matter where they go. So what about the future? So I was just saying earlier that we've been somewhat skeptical and somewhat cautious about proton beam therapy. So there's been a lot of interest in the field in proton beam therapy since after World War II, when nuclear physicists figured out that there was this phenomenon called the Bragg peak, which many of you who have to study radiation physics know about. So this is what photons do. They deposit their energy in a curve like this, and this is the depth in tissue. And then they have a gradient of dose deposition. Protons come in at sort of a medium level of dose deposition, but depending on their energy, they have a big burst in what's called the Bragg peak at a defined position in the body. So this has led to an initiative to develop proton beam therapy, but the problem is that you can have a LINAC that could easily fit in about the space of where I'm standing here, but proton units are pretty big. And you can see that these are sort of this, a person might be about as big as whatever these are in the picture. These are huge gantries. You need a cyclotron, you need a beam line, and these installations started out at about $150 million. And so initially there were only a few places in the country or in the world. MGH was one of the first, Loma Linda, MD Anderson, now Penn. But the cost was quite high. Now the reimbursement is also quite high, so people have been interested in doing it. But the problem is there isn't a lot of level 1 evidence to show that protons are better. It's more faith in the dosimetry. Now what does that mean in terms of dosimetry? Well, if you look at that Bragg peak, you can do what you call a spread out Bragg peak by using a mixture of proton energies. Instead of this is single Bragg peak, you spread it out and you get this dose distribution versus this one. So what you gain with protons is you don't have this entry dose. I mean, you don't have this big dose here, okay? And you also don't have an exit dose you don't have this because it stops. So this is what a photon would do, and this is what a proton would do. So in that little diagram, it looks great. The problem is they've been so expensive, and it hasn't been proven. It's generally accepted that in children, it's beneficial because sparing any healthy tissue in a child, especially at the doses we used, would avoid what we sometimes see as really devastating growth abnormalities due to radiation. We actually send a lot of our pediatric cases to Boston, to MGH for proton therapy when we think it's appropriate. But what's happened is in the past few years, companies like Mevion out of Boston have developed more compact solutions, and actually now a Mevion unit can be acquired for about $25 or $30 million instead of 150. And so we're actually now this year taking an active look at protons, and we're hoping that to pursue some kind of proton initiative in the coming year. Now, ironically, one of the people that has taken a close look at the value of protons versus intensity modulated radiation therapy is James Yu in our department, and he's done this not with our own patient cohort because we haven't treated any, but in national databases, and he's really a leading expert in using Medicare and SEER databases to look at outcomes in conjunction with Carrie Gross and in the Department of Internal Medicine. And what he found was that if you look at, there really isn't any long-term survival data showing any benefit of protons over photons for prostate, because as you know, you really need to carry that out to 10 or 20 years for early stage prostate. So it's been touted as having less side effect. But in fact, if you really look at what people experience, the difference in complications is trivial. And in fact, it's slightly lower in one case with conventional treatment. So when this came out in the Journal of National Cancer Institute, this was picked up by the lay press in all sorts of newspapers, magazines, TV shows, and really impacted the business plans of a lot of places, because insurance companies started to question whether they want to pay really 3 or 4 times as much for treatment for prostate. And in fact, Penn, with their installation, has decided to accept IMRT rates for proton therapy so they can still treat prostate patients, but they're doing it on a trial, which is the right way to go. Anyway, that's, this is part of the controversy over prostate. And so then you get some, headlines like this, a little bit older one, but, the risk is if you spend $100 million on a facility like that, what happens when the reimbursements come down? So this is some of the challenge, but I think now with the more compact units, the time is right for us to take a close look at that. So this is one example of a little bit smaller unit. This is about the size of a tennis court. This is made by a company called IBA. And then this is, I'm sorry, so that's the proton story. So the other initiative we're interested in, and actually we've had discussions with Dr. Geschwin to try to do this in conjunction, is now people are looking at the ability to build in, instead of a cone beam CT into a LINAC, to have an MR built in. And so there's one that's actually on the market now by a company called ViewRay, which is, it's not actually a linear accelerator. It uses a rotating cobalt source to do the therapy, but it has a magnet. And, in theory, it allows you could allow real-time imaging or close to real-time imaging of the tumor to allow motion management, or what people are starting to call adaptive radiotherapy. We're very interested in this too. One of the challenges in the current environment, though, is how many of these big-ticket things we can pursue at the same time. But I think in the next 5 to 10 years, a lot of centers are going to have MR-based LINACs, and we'll also go to MR-based simulation for treatment planning. So I'll just close with, an article from the New York Times from a few years ago and say that, this was when there was a number of stories about radiation over-treatments. And we're very focused on quality and safety. And this is really the main thing that we worry about every day. But especially as we go to these higher single fraction doses, making a mistake, a wrong side treatment, or anything that isn't quite right can be a very deleterious situation. So we have a number of faculty and people in our physics group and others that are very focused on this. Sue Evans is one of the leaders nationally in Astro on quality and safety, and it's something we think about every day. So with that, I'll stop, and I'm glad to answer questions.